let's go over first some basic principles. So, overview of the management of hypernatremia. So, firstly, you have to defend organ function. And so, if somebody has, severe AKI and uric from hypovolemia while simultaneously being hypernatremic, just focus on the volume deficit first by replenishing with isotonic fluids. Certainly if somebody's in shock, you don't want to be worried about giving hypotonic fluids in order to correct the hypernatremia in those early hours of management. First, get them out of shock. Okay. And so we've had a couple of patients like this in recent past, including one when I was on Parkland Consult with Sophie, where the serum sodium was greater than 180, immeasurably high, and the patient was in the the critical care pod of the ICU, hypotensive. We just gave isotonic fluids first, even despite that severe derangement of tonicity. Okay, so again, correct the organ dysfunction by just really focusing on correcting the volume deficit first. And then you can start to get fancy. And in order to consider how you want to correct this hypernatremia, you need to characterize the hypernatremia as an acute or chronic. By and large, most of these are going to be chronic hypernatremics. But if you do encounter an acute, severe hypernatremia, there's theoretically a risk of osmotic demyelination with that acute, severe hypernatremia. Again, that's a pretty unusual circumstance that you must kind of envision in order to be faced with such a patient. Most hypernatremics are going to be chronically hypernatremic. The analogy is similar to what we'll discuss with osmotic demyelination, is that when there is a discordance between intracellular and extracellular osmolality, you can get cell shrinkage as water moves outside of the cells. And presumably for a neuronal cell that is enveloped by myelin sheaths, this creates a risk of osmotic demyelination as that cell contracts. Okay, so you would correct those quickly. If you develop acute severe hypernatremia, just correct those quickly with tons of free water. For the chronic hypernatremia, the evidence for correction is weak. The evidence for correction rates for hyponatremia, the more common clinical problem that you'll encounter, is weak. The evidence for rate of correction of hypernatremia is even weaker. Okay. Most of this literature exists in the pediatric population for various disorders of failure to thrive. And, from that, you might extrapolate to a rate of correction of around 10 milliequivalents per liter per 24 hours. So somewhere in the same ballpark of the chronic hyponatremia. Now, once you've decided the rate of correction, you have to strategize and figure out how you want to correct that in some thoughtful way, okay, as opposed to the empiricism of give them hypotonic fluids, check the sodium a lot, and adjust as necessary. You as a practitioner of nephrology should approach the problem a little more thoughtfully than that. Okay? Now you have a couple of different strategies, and I've given you 3 different options here and rated them as least to most predictive. Okay, bear with me as I develop this argument. So you have the Androgy-Medeus equation. You can figure out how much is the free water deficit, and you could use that. You can even use the Androgy-Medeus equation in order to do that. You also figure out ongoing losses, and then you match the deficit plus the loss, the ongoing loss, or you do that in a more sophisticated way through Edelman's equation. Okay, so we're going to march through these three different options. Let's first go over the Androgy-Medeus equation. This is a formula that you can leverage for both hyper and hyponatremic patients. It is in fact a derivation arising from Edelman's equation as a first principle. So this is just an Edelman's formula, essentially, that has been simplified and basically says that you take this patient with a dysnatremia and distill them down to a closed system, a bucket, with some sodium concentration to start, okay? You do not consider outputs, okay? You do not even consider inputs other than, so no inputs other than the IV fluids that you intend to give, okay? And using Androgy-Medeus equation, you can derive the change in sodium by an IV fluid with a certain amount of water content and sodium and potassium content. So this is, again, an Edelman simplification with these caveats. No outputs, no other inputs other than the IV fluids that you give, and the individual is essentially a closed system, okay? That allows me to use this Androgy-Medeus equation. It says this will be the plasma sodium if you give 1 liter of fluid containing this much sodium and this much potassium, okay? It again does not account for ongoing losses or inputs beyond the IV fluids that you're given. So plasma sodium concentration, the change in plasma sodium concentration, is provided by the infusate sodium concentration. If you give D5W, that number would be 0. The K infusate would similarly be 0 if you're giving D5W. You have a starting plasma sodium. That's that sodium concentration at time 0 here, okay? And then you calculate total body water. You add 1. Where does the 1 come from? The 1 liter of fluid that you're giving, okay? Again, this is a derivation of Edelman's equation, a simplification of Edelman's equation. All right, now you can again use this same formula for hyponatremics. If you intend to, for instance, give 3% saline, you would say this is the sodium concentration change for an infusate concentration of 514 millimoles per liter. The K content would be 0. Starting sodium is whatever it is. If I gave 1 liter of 3% saline, this would calculate my predicted change in sodium concentration. Okay, so it can be used for both hypo and hypernatremia. That's strategy number 1 that has some modest accuracy. Now, the reason why you need to go deeper in many cases is sometimes ongoing free water losses are huge, okay? For instance, let's use again the example of a patient with diabetes insipidus, okay? Let's suppose you have a patient with diabetes insipidus. If you use Androgy-Medeus equation to, for instance, correct a DI patient who presents with a sodium concentration of 150, without accounting for any of the outputs, when in a DI patient, this output could be 10 liters. You would have a vast underappreciation of how much hypotonic fluid you must give in order to correct this sodium disorder, okay? So essentially, again, it behooves you, in order to get closer to reality, to know how much free water is being lost by the patient. Okay, so one can do that by using a formula which we've gone over previously, the electrolyte free water clearance formula. Okay, remember that electrolyte free water clearance formula basically allowed us to say, okay, this loss, in this case, usually it's urine, okay? I may be producing, let's say, 12 liters of urine. The electrolyte free water clearance is allowing you to say, of this 12 liters, for instance, 2 liters of it may be isotonic fluid, okay? If it's isotonic to the individual who has a sodium concentration of 150, it means this 2 liters does not change the sodium concentration. It would be as if you poked a hole in the bucket and 2 liters of fluid ran out of the bucket. The concentration doesn't change when you remove 2 liters of fluid from that bucket if it has a concentration of sodium of around 150. Right? It said the electrolyte free water clearance allows you to take this 2 liters of urine and break it down to about 2 liters, hypothetically, about 2 liters of isotonic fluid and 10 liters of just water. Okay. And it's this that is considered in determining the change in the sodium concentration. Okay. So that would be one approach. So formulas that you may use include a calculation of free water deficit from a formula you may be familiar with, current plasma sodium concentration over desired plasma sodium concentration, subtract 1, multiply times the total body water. This would be a way to know how much water you need to give an individual. If you want to give water plus electrolytes, okay, you can once again use Androgeomedeus. Where might I want to do that? I might have a patient who has simultaneously a sodium of 150 and a potassium of 2.0, right? You may recall that one of the acquired forms of diabetes insipidus is hypokalemia, right? Hypercalcemia is another electrolyte that can cause acquired nephrogenic DI. Hypokalemia can also reduce vasopressin responsiveness, is one of the forms of nephrogenic DI. Okay, I won't backtrack too much, but I'll just reference you this chart: nephrogenic DI, hypokalemia, hypercalcemia. Okay, so if I want to give an individual potassium and not just free water, or let's say they are hypovolemic, not in shock, but they're hypovolemic, right? And I do want to give them, if somebody is hypovolemic, in general, that means you need to give them salt. Okay, expanding someone's blood volume with free water will have very limited efficacy. Okay, if I give you free water, a very small proportion of that will end up in the intravascular space. You can in fact calculate that by knowing a few parameters, right? How much of water, where does water distribute, total body water, how much of that is in the ECF, what proportion is in the intravascular space. If you do that calculation, you'll find that water has very limited capacity to expand the ECF and therefore a limited capacity to expand blood volume. Okay, so if I have someone who's hypovolemic, you generally want some salt in the bag, even if they're hypernatremic. Okay, so in that case, you would not use just a free water deficit formula, go ahead and say, use Androgeomedeus. You prescribe a fluid that is hypotonic. For instance, I might consider using, in this instance, half NS plus 40 milliequivalents per liter of K, right? Or I might even use quarter NS with 40 milliequivalents of K, okay, to treat this patient who is hypovolemic and hypokalemic. Everybody get that? All right, so if I want to use salt, when do you want to use salt? Well, if they're K deficient, you want to use potassium salts. If they're volume deficient, put some salt in the bag. Don't just give free water. Use Androgeomedeus to predict roughly how much the sodium will change if you were to do just that. But then you have to add their ongoing losses to how much you're going to give the patient, right? How do I calculate ongoing losses? Well, one way to correct for the ongoing losses is to calculate the electrolyte free water clearance, okay? We went over that formula just for familiarity. I'll give you that quick glimpse of it again. Volume of urine times this term, okay? All right. If you want to calculate these non-renal free water losses, you might use a couple of nuanced bits of knowledge. You can estimate insensible losses at around 14 mils per kilogram per day. And if somebody is febrile, you add some more non-renal free water loss according to this formula. This comes from the literature, critical care literature. And then you also have to keep in mind that there can be massive amounts of loss of water as sweat in a patient who is, clearly febrile and sweating, okay? And or sweating. The final strategy in trying to, so let's say, accurately estimate the salt and water needs of your patient with hypernatremia is to use Edelman's equation, okay? This can take theoretically, you can use it in a simple form. You can also make it really fancy, okay? As I mentioned, Androgeomedeus is a simplified form of Edelman's equation. So you can be really fancy, or you can have, some limited capture of all the variables in a patient using Edelman's equation in predicting the change in serum sodium. It can take as many inputs and outputs as you want to try to capture, as long as you can estimate a volume of water and the electrolyte content, you can account for it, okay? So here's an example of how you might go about doing that, okay? You'll just tabulate, again, you can get quite neurotic about this. I'm only giving you these numbers so you can start to, nobody's going to, try to capture every single thing. But when somebody has a big influence, for instance, an NG suction where 3 liters are coming out of the patient, you should capture that, okay? I'm not suggesting that you use all of these parameters to capture perfect accuracy in predicting the sodium, right? But you should try and capture some of these things when they are big. For instance, we manage a lot of dysnatremias in people with ileostomies. And if they have a large ileal conduit output, or not ileostomy output, not a conduit, ileostomy output, you should capture that, okay? Or if they have a rectal tube in with, liters of C. diff stool, you need to capture that, okay? So here's how you might, again, begin to understand some of the normal electrolyte contents of various body fluids This comes from the surgical literature. In general, here's the average sodium and potassium content of stool. So if you wanted to, you can go, again, in principle, very fancy. You basically say, I have a patient with a starting sodium concentration, let's say, of 150, okay? And they have an initial sodium and potassium content in their body, an initial estimated total body water. As long as you can capture the tube feed sodium and potassium in tube feeds as a electrolyte content, which you can do from the internet, you can capture that, and you know that it was about 1.2 liters of tube feeding that went into the patient and water content, you can you can capture that, right? If it's an output, such as, ileal conduit, ileostomy, which has average electrolyte content provided here, right? An old ileostomy may have a total electrolyte content of 80 millimoles in terms of sodium and potassium salt that's leaving the patient. If they have 1 liter of that, well, then that's going to be 80 that you subtract and 1 liter that you subtract. That's in principle what we're doing with this big table that I'm showing you. You're basically just an accountant trying to say inputs of salt, inputs of water, outputs of water. That's all that this does. Okay, a lot of text and complexity, but in principle, that's all that you need to do. Here's where you can capture the inputs, recognize, interestingly, the metabolism of carbohydrates generates CO2 and water. Those are the end products of the glycolysis, TCA cycle, and oxidative phosphorylation. Okay, so you can even get fancy and capture that, is what I'm trying to say. Get really neurotic. Okay, all of this text essentially summarizes how you might go about doing that. I'll let you parse through that on your own time. Recognize that, we captured some of this insensible loss according to changes in temperature, as I highlighted in the text above. The sweat can be quite variable in its volume. And then again, here are some electrolyte contents of various clinical derangements. Okay? This formula allows you to calculate how much water you might want to give an individual with all of these inputs and outputs being captured, as complicated as you want. Okay? Questions about using Edelman's to predict changes in sodium? It's all just being an accountant. And you can be as neurotic an accountant as you choose to be. Make sure you get a little bit of neuroticism or their electrolyte clearance in the urine. That's easy. You should be able to capture that electrolyte-free water clearance. Okay? And if they have a large output like diarrhea, or a drain coming from their biliary tract. Okay, those are things to capture. Shifting to the chronic management of diabetes insipidus, and we're ending hypernatremia before segueing over to hyponatremia. Let's talk about nephrogenic and central DI separately. Okay, obviously, if there's a removable cause of nephrogenic DI, for instance, hypokalemia or hypercalcemia, correct those, okay? You can always allow free access to water. That should correct everything. As I mentioned, diabetes insipidus patients who are well don't present with dysnatremias. They present with polyuria because they have intact thirst, right? So someone who has hypernatremia will self-correct if you give them the opportunity to do that, right? And they will do that. The mechanism of that self-correction is thirst. Okay, so again, you can just let somebody respond to their intrinsic thirst desire, and then the sodium will correct. Okay, if somebody has debilitating polyuria, ways that you can manage that would be to reduce their osmolar intake through low sodium and low protein diet. Okay, remember, okay, we made the point that urine volume is equal to the osmolar excretion, osmoles per day, for instance, over urine osmolality. Okay, so if I am taking in 600 milliosmoles per day of solute, and I have DI, and my urine osmolality is on the dilute side, let's say 200 milliosmoles per kilogram, or I'm going to simplify to per liter, then my urine volume is going to be 3 liters per day. If that bothers me, one way I can manage the patient without affecting their concentrating capacity is to say, okay, eat less salt and protein, just eat 400 milliosmoles per day. If I do that, my urine volume falls to 2 liters per day. Okay, so that's one way to combat polyuria in a patient who has diabetes insipidus. A classic is, again, a lithium patient who can't come off lithium, or because of chronic lithium use, they have an irreversible defect in concentrating capacity. And if they're bothered by all that urination, you can manage that patient by saying, okay, well, make sure you eat less salt and take in some modest amounts of protein. You can add a thiazide diuretic. Essentially, what a thiazide diuretic does is volume contract the individual, okay? And if a patient has volume contraction, then more water is being reabsorbed in the proximal nephron. If more water is being reabsorbed in the proximal tubule, there is less water that is being delivered to the collecting duct. And if I have limited capacity to reabsorb that water through diminished aquaporin density in the collecting duct because of diabetes insipidus, then this can mitigate the polyuria, right? If I reabsorb more proximally, I have less water to escape into the final urine after traversing the collecting duct. Okay, so thiazide diuretics will tend to do that. Now, you might say, well, what about loop diuretics? Don't those cause volume contraction? Remember, however, the loop diuretic, which acts in the thick ascending limb, also influences the osmolality of the interstitium. And so if you reduce osmolality of the interstitium, I'll use this, by using loop diuretics, then the amount of water reabsorption that happens is less. Okay, so it is true. Loop diuretics can enhance proximal water reabsorption, but if it reduces also the medullary tonicity, then you're losing some of that bang for your buck, right? There's less water reabsorption in that DI collecting duct. Everybody get that? Alvin, do you get that? You seem to be pensive.
We have to restrict the water intake when using thiazide.
You restrict water intake in a DI patient? Never. Okay, that would be bad. Remember, if anything, free water, intact access to thirst and free water will resolve the dysnatremia. If you free water restrict a DI patient, you're putting them at risk of hypernatremia. Okay. You want to correct the polyuria without causing harm, right? Of free water restricting. If you do free water and restrict somebody, they'll eventually get so volume depleted that they will, they'll no longer dump as much free water because they will get pre-renal AKI. But that would not be good from a dysnatremia standpoint. Okay.
Does the patient have to sodium restrict when you're trying to use a thiazide?
Yes.
DI?
Yeah, because the goal is volume contraction. If you give somebody thiazides with barbecue and soup, then they will just pee more, right? Their polyuria will not be better. The reason polyuria gets better is you're enhancing proximal tubular reabsorption of water by volume contraction. Okay. Didn't mean to single you out there. Okay. Okay. All right. I myself am on a plenty high salt diet, so I'm no angel myself. Okay. All right. I do use sodium potassium blend salt at home now. Okay. All right. My mom refuses to use it when she comes. All right. So you can, if you're courageous, consider using non-steroidals. Non-steroidals, if anything, tend to lower serum sodiums, right? We went over one cause, as we talked about physiology of water transport. We talked about prostaglandins being important in regulating aquaporin activity. And so non-steroidals enhance water reabsorption through aquaporins, even in the face of limited vasopressin. Okay. So non-steroidals also decrease GFR. If I decrease GFR, then I'm filtering less water for water elimination. Again, it would be a bold move to do that, but in truly refractory patients with severe, DI, complete DI, you might consider that. Okay. And for patients who have partial nephrogenic DI, you might consider giving them even higher doses of physiologic, even more vasopressin essentially than they have. Now, that would be of limited benefit, right? Because in general, patients, well, actually, it could be of benefit because, again, DI patients who are normonatremic will not have intrinsic vasopressin levels that are exceptionally high, right? So giving DDAVP can, again, try and augment water reclamation. Amiloride might be used, especially in lithium-induced nephrogenic DI, if cessation of the drug is not an option, okay? Amiloride is a sodium channel blocker. It is thought that some of the effect of lithium is mediated through the internalization of lithium via ENaC. Okay, so when you are using amiloride, you're trying to reduce the amount of lithium that is internalized in the tubular epithelial cell. Okay, so amiloride may reduce some of the effect of lithium if you can't stop the lithium. Okay. It does not help if you have permanent lithium-induced diabetes insipidus that persists despite stopping lithium. Okay. It's really just trying to reduce the amount of lithium exposure to the tubular epithelial cell. Okay. For central DI, again, free access to water is a solution, but if polyuria is limiting, DDAVP is your tool of choice. Okay, and it's very effective. You can give it as a tablet. It's also available as a nasal spray. Now you have to be careful with it because if a patient has some compulsory or compulsive water drinking, as some people do these days, you can get hyponatremic. But as long as you tell the patient, well, don't drink just if you're not thirsty, it shouldn't, you should have the ability to regulate your thirst. You would not drink yourself to hyponatremia if the patient just uses their brain to regulate how much water to drink. Okay. You can also use low sodium diet, low protein diet, and a thiazide for central DI if you can't get, desmopressin. Okay. For instance, if you don't have insurance, right? Desmopressin would be more expensive than simply thiazide diuretics through the, through the GoodRx. Okay.